Hello, everybody. Welcome back to another MedFit Education Foundation webinar. Awesome topic today. We have a special guest, Dr. Carla DiGirolamo, and her topic for today is hormones and you. Knowledge is power. Let's see. All right. About the presenter, Dr. Carla DiGirolamo is a double board certified obstetrician, gynecologist, reproductive endocrinologist who specializes in care of reproductive age and midlife women. All right. She is also has been in the fitness industry her entire life. She's a level 1 CrossFit trainer, certified nutrition coach, and we just talked about her awesome workout setup at home. So as MedFit can be with this one, and we are very excited to have Dr. DiGirolamo on today. So without further ado, welcome, Doctor.
Well, thank you, Brian, for the introduction, and thank you to all of you who are joining today and watching the webinar. So I'm going to show my screen. So I'm going to pivot a little bit today with this talk. We are going to talk all about hormones, so not to worry. But what I decided to do, because hormones is such a big topic, I could talk for days on this straight. And what I wanted to do was really make this talk relevant for fitness and wellness professionals for what you're going to see day to day. So with that, let's get started. All right, so the basics. What is a hormone? So hormones are chemical messengers that are secreted by cells within tissues and organs that are secreted into the bloodstream for the purpose of communicating with other tissues and cells and organs in the body to elicit a certain response. Receptors are proteins that are on the surface of cells that bind to these hormone chemical messengers and translate the hormonal message to the cells and tissues to carry out a particular function. So here's a pictorial example. You see on the left-hand side, there's a square around a little blue clover there. That's a hormone that's been secreted by a cell, and it's traveling through the bloodstream with all those little red blood cells. And then it arrives at the tissue and it lands on the surface. So the little ball there is the hormone and the little Y is the receptor. And as you can see in the third panel, that receptor communicates with the inside of the cell. So when the hormone binds to the receptor, it sends a message to the inside of the cell so that the cell knows what to do. So some key points about hormone receptor interaction for the purpose of this talk is that they are specific to one another. They're like locks and keys that fit together a certain way. So not just any hormone can interact with just any receptor. Tissues can regulate hormone signals by upregulating and downregulating the number of receptors on the surface of the cells. So when you think about receptors, think of them as little antennae that are receiving a signal, which is the hormone. And so when you want to receive more signal, you create more receptors on the surface of the cell. When you want less signal, the cell can reduce the number of receptors on the cell. It's like turning up the volume and turning down the volume on your radio. If you want a louder message, you turn it up. If you want a softer message, you turn it down. And then tissue communication via hormones is a biochemical conversation where hormones are the voice and the receptors are the ears. So the menstrual cycle is an excellent example of a hormonal conversation. So I'm going to demonstrate this. On the left-hand side here, that's the pituitary gland. And so when the menstrual cycle is beginning, the pituitary gland wants to tell the ovary that it's time to make an egg. So the pituitary talks to the ovary via the hormone FSH, follicle stimulating hormone, and says, hey, it's time to make an egg. So the ovary hears this message, says, oh, pituitary gland wants me to make an egg. All right, I'm going to make an egg. So the ovary makes an egg, and so now the ovary has to say, all right, the egg's made. Got to tell the pituitary that we have an egg. And the way the ovary does that is through the hormone estrogen. So the pituitary now hears this estrogen message and says, oh, we have an egg. Let's ovulate. So the pituitary gland then has to tell the ovary, okay, it's time to release that egg. And the pituitary gland does that via luteinizing hormone, or LH. That is the hormone that one detects on their ovulation predictor kits at home. So the ovary sees the LH and says, oh, time to release the egg. So the ovary releases the egg. So now we need to bring the uterus into the conversation, because now the egg's been released, pregnancy could happen. So the uterus now needs to know that it has to get ready. So the ovary tells the uterus, hey, we released an egg, there could be a pregnancy happening. The uterus says, okay. And that message is coming to the uterus via progesterone, which is secreted by the ovary after ovulation. So the uterus goes and starts getting the uterine lining ready. Then the sperm comes along, and then pregnancy happens. So now the baby becomes part of the conversation through the hormone HCG, human chorionic gonadotropin, because the baby has to tell the ovary, keep that progesterone coming, I'm here, I need you for the next 3 to 6 months before the placenta takes over. So the ovary is like, oh, wow, there's a baby here. Let's just keep producing that progesterone. And the ovary is like, okay, we've got a pregnancy. I mean, the uterus is saying we have a pregnancy here. We have to sustain this. So say baby doesn't come along. Ovulation happens. The sperm doesn't come along. The ovary is waiting to get that HCG message from the baby. So the ovary is waiting about 7 to 10 days and says, nothing's happening. Time to start over. Then the progesterone stops producing progesterone. Progesterone levels go down, and menstruation happens. And then the whole cycle starts all over again. So that is an example of a hormonal conversation. And the menstrual cycle is a rhythmic, predictable conversation among the hypothalamus, the pituitary gland, the ovaries, the uterus, possibly a pregnancy, where the hormones are the language that they use to communicate. Now, during the menopause transition, this hormone receptor conversation becomes disrupted, because during this transition, this normal transition that every woman goes through, the ovary stops eventually producing estrogen. So the estrogen levels are going down during the transition to menopause, and then finally they are at very, very, very low, barely detectable levels. And so when that piece of the conversation is missing, the receptors in the tissues that respond to estrogen are like, okay, well, turn down the volume. It's time to kick back. And so the change in the hormones and the change in the receptors, which is the tissue's responsiveness to the hormones, that change creates this disruption and chaos of that hormonal conversation, because now a very critical piece of that conversation is missing. And a key point to remember here is that there are estrogen receptors found in nearly every tissue of the female human body. And that means that estrogen has a function in nearly every tissue of the female human body. So when estrogen starts to decline and that conversation is disrupted, it affects lots and lots of tissues. And that's why the menopause transition is fraught with so many symptoms, because so many bodily systems are being affected. So what we're going to focus on is the skeletal muscle, the musculoskeletal system, and its, why did that do that? And it's how it's impacted by the menopause transition in these changing signals. So let's first talk about skeletal muscle. It connects bones via tendons and ligaments to facilitate movement. It comprises 30 to 40% of total body mass. Skeletal muscle is voluntary, as opposed to smooth muscle of the gastrointestinal tract, which is involuntary. It's very metabolically active, as you'll see. And there's a complex interconnection with the nervous system. So the smallest functional unit of skeletal muscle is the muscle motor unit. And the muscle motor unit is comprised of a motor neuron or a nerve cell and the muscle fibers that it innervates or connects to. Motor neurons carry electrochemical signals to the muscle cells of the motor unit to initiate and coordinate contraction and thus movement. So some of the factors that impact muscle function overall include muscle mass, how much muscle someone has, nutrition level, activity level, comorbid medical conditions, medications, and the place in the female reproductive continuum has a real impact on the function of skeletal muscle. So the reproductive continuum obviously starts with birth. Puberty is the first big hormonal change a female will go through. Many women will experience pregnancy, which is another huge overhaul of hormonal change. And then finally, menopause, which is the return to reproductive quiescence. And menopause, of course, is what we're going to focus on today. So what is it? Let's talk a little bit of what menopause is exactly. It is defined as 1 year from the final menstrual period. The average age of the onset of menopause in the United States is 52. Ovarian production of estrogens and androgens, which are male hormones, declines. That is what characterizes the initiation into menopause. And there is a transitory period from the time a woman is able to still conceive and have children to that last menstrual period, and that's about 4 to 6 years on average. So that transition starts to begin at about age 45, and it's called perimenopause. Then there are special cases where there's premature menopause. These are women who have their final menstrual period before the age of 45. This could be just natural early menopause with no certain cause, menopause secondary to chemotherapy or radiation, and surgical menopause where a woman has to have her ovaries removed. Now, systemically during the menopausal transition, what's happening is how her body processes nutrients changes. Physical activity as we get older in general is reduced. It's very true in the menopause transition as well. There is impaired recovery from exercise, many times due to sleep disturbance or nutritional change that comes with this phase of life. During this time, there is a higher instance of comorbid medical conditions and taking medications. And we also find a higher incidence of insulin resistance, lipid changes such as with cholesterol, fat distribution, and weight gain. And these are things that you will see with your clients because that's many times the reason they're coming to see you. Now, what happens in the skeletal muscle during the menopause transition? So we start to lose muscle mass, and the muscle's response to estrogen is also changing. There is a reduction in estrogen receptors during the menopause transition in skeletal muscle tissue. There is a shift from type 2 fast twitch explosive muscle fibers shifting more to type 1 slow twitch endurance fibers. So what women athletes or recreational athletes might complain of is like, I just don't have a lot of power. And that's what's happening is those type 2s are now exchanging themselves in for type 1s. And so that is perceived as like a loss of power. There is reduced speed and efficiency of some of those neurological signals between the nerves and the muscles. There is also a reduction in protein synthesis within the muscles needed for muscle repair and adaptation. And there is also a sensitivity to oxidative stress from cellular damage that accumulates with age. So now we're going to talk a little science-y. So let's all take a cleansing breath, and I promise I'm going to make this simple, okay? But science is really important because almost everything we know about reproduction is rooted in what we have learned from mice and primates. So when scientists want to know how something works, they can genetically engineer a mouse to knock out that function that they're interested in testing. Okay, so the receptor that scientists have wanted to look at is estrogen receptor alpha. There's alpha and there's beta, but for the purpose of this talk, we're going to talk about alpha because that's a really important one. So when scientists wanted to learn what estrogen receptor alpha did, what is important about it, they engineered mice to not have estrogen receptor alpha produce. So they knocked out that function within the mice. Now we know that estrogen receptor alpha is on the surface of muscle cells, liver, fat tissue, and on the mitochondria. So it'd be interesting to see, well, what happens when you don't have estrogen receptor alpha? Well, what they did was they knocked out the function of this gene that produces this receptor. And what they noticed were these mice were obese, they were glucose intolerant and insulin resistant. So very similar to the metabolic syndrome we see in humans. So what they learned from many studies looking at this was that the estrogen receptor alpha pathway is critically important for metabolism. So I alluded to the mitochondria because it is very, very important. It is at the crux of what happens within skeletal muscle during the menopause transition as a response to declining estrogen and estrogen receptors. So what are mitochondria? Mitochondria are like these little batteries that you find in the cells, and they supply the cell with power. They produce energy. They are in all cells of the body, and they actually even have their own DNA inherited from the mother. So they are super, super, super important. And the way mitochondria serve as batteries have to have a charge, right? So if you look on the right-hand side here, you see ATP and ADP. So TP means triphosphate. There's 3 Ps there. Think about that as like the bars on your cell phone. So when you got 3 bars, you're fully charged. And then when the cell phone's used and power is generated and energy is expended, it goes down to 2 bars. So there's 2 phosphates. And then the body just recharges the batteries using the ADP ATP system. So think about ATP as the bars on your phone, and the mitochondria are your little rechargeable batteries. So on the top, I'm going to give you a context of just, well, where do these little mitochondria live? So on the left-hand side, you see skeletal muscle. That's a skeletal muscle fiber connected to a bone. The next panel to the right shows actual muscle cells. And so if you hone in on that little muscle cell, you can look in on the next panel, the little square, these little blue sausage looking like things. Those are the mitochondria. And different cells have many mitochondria. Some of them have very few. It depends. Muscle cells tend to have lots of mitochondria because they need lots of power because they're working all the time. So as I mentioned before, they look like these little blue sausages that live within the cells. And so from the mouse studies, when they knocked out the function of the estrogen receptor alpha and impacted mitochondrial function, what they found was that there's a loss of muscle power and contraction, resulting in a loss of strength. The uptake of glucose into the muscles via insulin is reduced, because that estrogen receptor alpha is not functioning properly. So that results in glucose intolerance. It results in adiposity because of changes in fatty acid oxidation. And there's also impaired cellular repair. So this results in inflammation because the tissue cannot repair itself from wear and tear as effectively because estrogen receptor alpha is changing, and so is the cell's response to all of these processes. So if the last 3 slides were really not so clear, this is the one slide you want to focus on. And so some of the conclusions from these studies were that estrogen receptor alpha is really super important for muscle mitochondrial function. Mitochondria are the batteries that supply the cells with their power. Uptake of glucose and response to insulin changes when estrogen receptor alpha is affected and changes. When the mitochondria dysfunction, it results in insulin resistance, increased fat storage, increased inflammation, and ultimately in the muscle cells, it's reduced muscle strength and muscle mass. So loss of muscle mass, impaired function can increase the risk of falls, fracture, physical disability, impaired metabolism, metabolic syndrome, and reduced quality of life. And here is where fitness professionals can make the greatest impact, even greater than what their physicians are going to be making, because this is really where the prevention and the treatment of these impairments really lies. So it lies with us as the fitness professionals. Because the changes that occur in muscle and bone during midlife transition is what is the driver of how we create training foci. So if you have knowledge of what is happening to the muscles during this phase of life, we can design fitness programs and nutritional programs so that we can meet the needs of these women in this dynamic phase of life. So when you're training midlife women, the key principle here is that we need to provide another avenue for muscle stimulation. So when estrogen hormone and estrogen receptors are now on the decline, we need to find another way for the muscle to respond, for it to stay functional, to keep the muscle mass going, etc. So how do we make this end run around this inevitable hormonal change that women will go through? So there's a number of ways we can do this. And basically, you got to keep the body guessing, because the human body is tremendous at adaptation. And so to mix up the stimuli is the best way to keep the muscles guessing and stimulated and interested. So the first thing is, trainers, especially the 20 somethings, let your midlife people warm up a little bit longer. It takes a little longer for us to get those cobwebs out. Pain perception in the joints is a little different at this stage of life, so we need a little bit more time. So keep in mind that that we need a little more warm up than the 5 minutes that the 20 somethings could probably handle. Varying intensity, incredibly important. Again, this is part of preventing that adaptation and keeping the muscles guessing. You need between 2 and 3 high intensity days. And it obviously depends on what the skill level is or the athletic level of your client is. But you need those soul crushers every once in a while. Now, not every workout should be a soul crusher because of, repair and recovery, but you need a couple of them during the week to keep the muscles guessing. You need some moderate intensity exercise, as well as 1 to 2 low intensity or active rest days that will help facilitate recovery and tissue repair. Heavy strength training, so important for midlife women for muscle health and bone health. And this isn't 10 sets of 10 reps. This is heavier lifts for fewer reps, 3 to 5 reps. Now, heavy lifting should never, ever, ever be compromised for sound mechanics. What heavy means is what she can do for 3 to 4 reps challenged with stone cold, excellent mechanics. Because the risk of injury is real, right? But that doesn't mean we stop doing the movements. We just make sure we do the movements safely. So you need that heavy lifting to stimulate those type 2 fibers that are now going away during this stage of life. That's the type of stimulus they need. So they need some good instruction, good coaching, and good training on how to do some heavy lifts. Core strength, also paramount. Again, the joints get a little bit lax because of the loss of muscle mass in the rotator cuff, sometimes the muscles surrounding the knees. So the core, which is the foundation of functional movement, is what needs to be strong. You need a strong foundation so that movement can be effectively executed through the joints and so that injury doesn't happen. HIIT training, high intensity interval training or sprint interval training, is great for the cardiovascular system. There's lots of research on this, of the benefits to the heart and also for body composition. Plyometrics, excellent for bone density. And the key with plyometrics is that you want to mix it up, right? You don't want to just run. You don't want to just skip rope. You want to do many different things because, again, the bones adapt and you got to keep them guessing. And so multi-dimensional, multifactorial types of plyometric training is optimal. And also mobility and mindset. I love yoga for this. Mindset's so important because women are going through so much during this phase of life. Their body is just doing some unexpected and sometimes scary things. And so that mindset work helps to reduce that stress level, help her be in tune with her body, and the mobility and tissue care is really important for the recovery. Now, I have a blog. It's called Athletic Aging, and it's on the Substack platform. It's you can find it at athleticaging.blog. And I just want to tell you about these 2 posts that I had posted recently. One is on grip strength, and the other is on body composition. Body composition, your clients will probably be inevitably talking to you about, so you can go ahead and read that. But grip strength is interesting because it is, as many of you might know, it's a nice bedside, easy way to assess what someone's overall body strength is. And this correlates with overall health effects and risk of morbidity, mortality, things like that. So they're starting to now use it in menopausal women to try to predict potential health issues down the road, and so that you can mitigate that risk with training and nutrition. So again, check it out on athleticaging.blog, and you can read the review of some of the studies in the menopause literature looking at grip strength. And also, just in the interest of time, I put some sample workouts on grip strength and how this translates into overall body strength. I put a couple of sample workouts there. This one here involves some pulling movements and intersperse that with burpees. Got to always do burpees, right? And some options. And also this is sample workout 2, which focuses on some plyometrics and some either deadlifts or farmer's carries. On the blog, there are other functional fitness workouts that you'll see as well. So here's my contact information. I do have an online coaching, fitness and nutrition coaching business at Fit for Life MD. I just mentioned my athletic aging blog. You can also find me on Facebook, Instagram, and LinkedIn. And you can also feel free to reach out to me via email. My contact is there if you have any questions. So with that, I thank you for your attention and the opportunity to speak to you today.
Excellent, excellent, excellent. Thank you very much. Let me grab the screen back from you here. All right, now we'll get to some question and answers here. I'm going to pull them up, but I do have a few of my own, so bear with me one moment. Okay. Let's start with, first of all, right off the bat, so excellent. So that was not a question, but just a comment on your presentation here today. So I agree. I thank you very much. We have some questions here. If estrogen receptors decline with age, does hormone replacement therapy bring them back?
It does not. Because when one takes hormone therapy, it is not reproducing the hormonal environment of natural hormone production. Natural hormone production is under very, very complex regulatory mechanisms. So hormones are often secreted in pulses. It varies with the circadian rhythm. Within the cells, there are enzymes that convert hormones to different things. And when you have so many changes to these regulatory pathways, taking a pill doesn't reproduce that. So because you can't reproduce the hormonal environment, you can't reproduce the tissue response to it. Now, hormone therapy treats symptoms, and there's things that hormone therapy treats very, very well, but it doesn't reproduce the native environment that was once there when you were 30 years old, because there are layers and layers and layers of regulation at the cellular level and even deeper at the genetic level that we just can't fix with hormone therapy. The receptors are there. Sometimes they can transiently be upregulated, but they're just going to downregulate again.
Okay, fantastic. I had a couple questions for myself about the reasons that maybe a client would come to a trainer. Obviously they might be training for their general condition. They're training just for their age, or they're training because that's what they like to do, or they're training to, the standard things that we always hear is lose weight and tone up. But perhaps they're falling into the age of menopause, where that would take place. Is it something that, we see the trainers, or, that they would train for menopause and follow those guidelines that you laid out with the HIIT 2 to 3 days a week, or the intensity and the strength, coupled with that at least 2 days a week? Do you feel that those would be best? Are we kind of changing our outlook on how we train the client based on menopause, or on their needs and what they're kind of looking to do in just personally?
It's a combination of things. One of the most common things you're going to see when a menopausal woman, signs up for training sessions with you is she's going to say, I'm gaining weight. I've got this accumulation of fat around my belly, and the body composition changes that go along with that. And she's probably going to tell you the things that worked before don't work now. I can't control this. I don't know what's happening. And so that's kind of the general physiology of what's happening during menopause. Now, you may have an elite athlete. I work with a lot of elite athletes, and they're experiencing this to a different extent because they're already elite athletes, but they're still having some issues with muscle power and endurance and things like that, and body composition changes. And then you have your, just your casual recreational athletes who may have different goals. and they may have a different fitness level. So the principles that I mentioned are basic principles you can apply to any situation. But just keep in mind that these physiological changes are happening in the midlife population, and then depending on what her goals are, her situation, her fitness level, you can then tailor those basic principles to exactly what her needs and goals are.
Sure thing. Always have an understanding of who you are working with, right? And what they
That's
may be
right.
encountering that they may not consider, as being part of, the issue, problem, or the thing that needs to be changed. I love it. Let's talk quickly. We do have a question here about um, nutritional changes as we go
Mhm.
through this. Let's talk about that if you don't mind. Is there a dysregulation in the CHO metabolism? Should we be considering low carb approaches? That is a question from Rick.
It's a really great question, Rick, and it's complex. But one of the things that's happening in midlife women is that they're becoming more insulin resistant. And this is why I really wanted to focus the talk today on the changes that occur in the musculoskeletal system, because the muscles are a huge utilizer of glucose and really play a big role in managing sugar. So what you'll find in many of these women is that they're more sensitive to those simple sugars and the simple carbohydrates. So they may need to shift, if they're experiencing more fat deposition, they may need to shift over to more complex carbs. They might not be able to have that piece of cheesecake every Saturday night like they used to when they were 30, if they want to, maintain their body composition. So they may have to make that shift. Nutrient timing with exercise also becomes a little bit more important. I know some of the older studies that say nutrient timing doesn't matter. Most of those studies were done on men, and maybe in men it doesn't, but in women it can. So, the utilization of glucose right before a workout and right after is important too. So, minimizing those processed sugars, simple sugars is a good idea in this population. Also, nutrient timing is a good idea as well. And also keep in mind that in this stage of life, fatty acid oxidation tends to be a little bit more dominant in this age group. And again, it's going to depend on what her physical activity level is. An endurance athlete is going to have different carbohydrate metabolism and utilization than the CrossFit athlete who's doing a lot of heavy Olympic lifting, because exercise also impacts how the body utilizes sugar. So those are all things that you're going to want to take into consideration. But insulin resistance is a real issue for all of the changes that I mentioned during the talk, and is something to pay attention to.
Okay, good. And how about the person that is not the endurance athlete nor the CrossFit athlete? They are someone who's, just generally there for their overall health. Is that something that we change that protocol at all?
Well, it depends. What's her goal? If she's coming to you
Sure.
saying, look, she's at a healthy weight, she feels good, maybe you do a food log, see what she's doing, maybe you tweak a few little things, but if it isn't broken, let's not fix it. Nutrition
Sure.
may be something that she's doing really well, but it depends. If she's complaining of body composition changes, then you may have to take a deeper dive into her food logs and see what is she getting for carbohydrates. But
Okay.
it depends on her goals of what she wants to achieve.
Okay, good. Of course, once we open up the door to nutrition, here come the questions rolling. Uh, Time restricted eating window for post-menopausal. Any changes to that? Are we following the normal guidelines or suggestions, or is it a, find what works for you type of situation?
So those kind of questions kind of start to get into intermittent fasting. Is this good? If you follow Dr. Stacy Sims, she is one of the leading exercise physiologists, nutrition scientists who studies age differences and between men and women in these types of things. And also she does a lot of work in midlife women's age group. And I recently took a course with her that showed quite a lot of data that says that intermittent fasting is not good for this population. And one of the reasons, and I didn't really dive into this in the talk, this could be a whole separate talk in and of itself, is the way it elicits the stress response. So women in this stage of life are very sensitive to stress, meaning the cortisol response. And so when the cortisol response is in full gear, what the body does is it hangs on to fat, it hangs on to fuel, because it thinks it's starving, it thinks there's stress, it thinks, okay, I got to kind of hang on and get ready for, the storm ahead. So when one goes through, either fast for 24 hours or, 12 to 18 hours, that can produce or invoke the stress response, which actually can have the opposite effect. And because the body is going to get stressed and hold on to fat more. So what is evolving now is that intermittent fasting is not a good idea for this population. So, usually you want to tell people, don't eat, for 2 hours before you go to bed. And then by the time you get up, 11 hours has gone by before you have breakfast. So, that's about the extent of quote unquote fasting. That's just healthy living, and not, eating 1,000 calories an hour before bedtime. So you just want to kind of stick to the common sense stuff. But that's some of the data that's out there on intermittent fasting in midlife women.
Excellent. And thank you for that, because that, is one of those topics and suggestions that's, is thrown out anywhere from, friend circles and the internet searches and, news, checkout line magazine covers and things like that. But right now we're talking research from an expert in the field. So we appreciate that. And I'm glad that was asked and brought up. Okay. Is the weight gain caused by menopause unhealthy, or is it just a natural occurrence that should be accepted?
It depends. If a woman gains 30 or 40 pounds and now she's in the obese category where her cardiovascular risk factors are going up and maybe her, lipids are changing, that may not be such a healthy thing. And that many times can happen, because one of the things that's very common in this population is depression and anxiety. These changes in the hormones impact the brain. If people have a history of depression and anxiety earlier in life, they're at even greater risk of this happening during the perimenopausal transition. And even if a woman doesn't have a history of this, she is at higher risk just because of the hormonal changes in the brain. So what many women do, as we know as nutrition coaches, is they eat in response to stress. And so that kind of stress eating in response to anxiety and depression is something that we really need to identify, and so to start to change those habits. So that's more extreme, but yes, absolutely. If you are still within that healthy weight and you have a little bit more fat gain, that is absolutely okay. It's protective, because we know that excessive thinness is a risk factor for osteoporosis. So you want to stay within the healthy range. You just don't want to get into the obesity situation where you have disordered eating and you have negative cardiovascular impact. So healthy weight, 5 to 10 pounds, if there's, cushion there, she's a healthy weight individual, I think that's absolutely okay. But does it bother her? That's the other question. To what extent is this impacting her quality of life? So complex thing to assess with our clients.
Okay, good. When I hear that, I think it has so many similarities to pregnancy. The things you eat, and the weight that you gain, and what's useful and what isn't, and it's just there's so much going on there. But it always kind of comes back to some of the tools that we may already have used, throughout their life. Okay, let's see here. Well, you did touch on the mental, or the anxiety and the worry and all those things that will come in along with it. What can we do? I know you mentioned yoga and some mindfulness practices What can we do aside from that, maybe to put them at ease? How much is sleep important to that? You know, obviously food goes in hand in that, and exercise can be medicine for those things as well. Just touch on that, if you don't mind, a little bit more about how that will affect this client.
So sleep is incredibly important, and that's one of the first things I ask my clients about. And as a physician, that's what they're telling me when they come and they're having hot flashes. The first thing that's disrupted is their sleep. And when sleep goes awry, the cortisol response, that stress response is back. That gets triggered, and that is, you know, it's a huge issue. So basic sleep hygiene, you know, I think is very, very important. You know, turning off the devices, you know, a good hour before bed, being in a calm environment. You know, don't have your desk and your laptop in your bedroom. Don't use it as your home office. Just use it for sleeping. Minimize your caffeine after, after 3 o'clock. All the basic sleep hygiene stuff is really important. So you want to go through that with your clients. And if your client is saying, look, I do all that, you know, I really do, and she's got it all documented, you might want to have her start doing some sleep diaries, or even have a sleep study done by a sleep specialist, because maybe she's got obstructive sleep apnea and she doesn't even know it. You don't have to be obese to have obstructive sleep apnea. So there could be other zebras out there. You know, we're thinking, oh, well, it's hot flashes. Well, it might not be, you know, it might be something else that's going unidentified. But sleep is critically important for minimizing that stress response and for recovery from, you know, anything that she's doing during the day.
Okay, good, good. All right, let me see here. I'm just going to go down the list once more. Teresa Brown had asked if you could spell the name of the nutrition doctor that you mentioned. It was Dr. Stacy Sims, I believe.
Sims, yep. Stacy T. Sims, S-I-M-S. She is outstanding. She's a former, I think she's a triathlete. She might have been professional at one point, but she's a brilliant mind in this area. She has a course called Women Are Not Small Men, and again, that is the sex differences that she has studied for her entire doctoral career. And she has another course that I took myself called Menopause for Athletes, which is more geared toward avid recreational and elite level athletes who are going through this. So really, really great stuff in her work. So I would definitely check her out.
Okay, great. All right, here's another one. What is a healthy body fat composition for women post-menopause?
I mean, I don't think
Depending
it's
on the
really
individual?
it's really not different from, you know, what we consider a healthy body composition to be. You know, we consider a body mass index of 30 to be, you know, obese. We think over 35 is morbidly obese. You know, I think all that applies. And I think there's a range of what's healthy, because, you know, you also have different body types, right? You got your ectomorphs, your mesomorphs, your endomorphs. And so what is healthy for one individual may not necessarily be healthy for the next. So you have to kind of see, okay, well, what's their body type? What has been their trajectory? And you have to think, well, what medical problems does she have? If she has high cholesterol, okay, she might be on the thinner side. But if she has high cholesterol, she might have to, you know, stay within a tighter weight range than somebody else. So I can't say that there is one weight range that is healthy for a perimenopausal, postmenopausal woman. It's the same as everybody else. So it's really not that much different. But you have to take the individual into account in what their specific situation is.
Right. This is just one aspect of who they are and what they're hoping to accomplish, and where they, you know, age is a factor, of course. So that would put them in maybe a different box, so to speak. But it's no different than you know, anybody who's trying to live a long, healthy life. You know, all these angles must be reviewed and detailed and visited, you know, different doctors, and make sure that you get in your checkups and you understand where you are, what your baselines are, what you need, you know, all important things here. Let's see here. You brought up something that was very interesting, that to me is that, and here I am, a male who's hosting this particular webinar, and you said that, you know, many of the studies were performed by male physicians or male doctors or male researchers, you know, whether it was a while back. How is that coming along? Are you seeing more female-led research in this, or, has there been, better research maybe performed as a female begins to, or, gets more into their own body and situation and their reality than ours?
It's so damn slow. And you're touching on something that is, it's kind of like, I don't know. There's just not a lot of research on these on this age group of women, and there really needs to be. And we just had the 50th anniversary of Title IX, and so now we're seeing these women, active women in sport, coming into this phase of life. So we're seeing it more and more and more. And so I think there is more study, but it is really, really slow and really insufficient. Because I think, in American society, and also maybe in other societies, I can't really speak for Europe, Canada, I'm an American, is that, when you get to be that age as a woman, you just kind of kick back, forget about it. You're going to die on the vine and just, throw your hands up. And women are not accepting that, nor should they. And I think that prevailing attitude toward women in this phase of life has resulted in really not making the effort to learn about them. But
Right.
you've got prominent people, like I mentioned, Stacey Sims and lots of others out there who really are paving the way in research in this population. So I hope to see more, but it's a little slower than I'd like, but it's coming. It's coming.
Yeah, I mean, it's a great point, and when you said that, it's almost as if, the society or the research or the medical care, it seems like the woman has done what we need them to do by this point, and they've, have had born children, and now, we just kind of continue on and enjoy your golden years. And yeah, it's I think that's something that is exciting, that you say that, it is more information is out there, and it's, it's being worked on a little bit more. But yeah, no doubt about it, it's something that, it may have been tossed under the rug for far too long. So great to hear that it's something that is on the forefront and cared about more than it ever probably has been. One other thing that I thought of is, what about the client? Again, I kind of touched on it earlier, who's never really exercised before, and now they're having these changes, and they're having these things that they're going through, that is kind of not forcing them, or maybe opening their eyes to, or introducing them to exercise. Obviously a big difference for somebody like that. What's an entry level? I mean, is it walking? Is it, we do want to make sure we hit all those puzzle pieces that you laid out with the hit and the strength and all those things. But we're talking like really entry level, somebody saying, I've got these changes going on in my body. I don't feel good. I need somebody to help me. Where do we begin with all this?
So if a woman is coming to you with changes that are consistent with the menopausal change, the first thing she really needs to do is see her physician, because these changes that she's experiencing could be due to underlying medical conditions that have not yet been discovered. And those things need to be addressed and solved. And that can't be done by the fitness or the nutrition professional. So when women start to experience these things, it's important for them to see their physician and really take a deep dive into what these experiences are, so that the first thing you can do is rule out chronic disease. Is she having hot flashes because she's perimenopausal, or is it because she's got an underlying thyroid problem? You have to figure that out. So you want to encourage people to have a physician visit and just get their finger on the pulse of what their health status is. Once that happens, and say she's healthy, she doesn't have any underlying medical problems, and I think you do your normal exercise assessments. I think that's the first thing, like you would do with any client, whether she's a reproductive age woman or whether she's an older woman. The first thing you're going to do when you meet her is you're going to, decide what assessments are appropriate for her. And so you kind of just treat her like any client. I think what changes in this age group is what her goals are. If she is complaining of the the body composition changes, you're going to want to address that. Take a look at nutrition. If she is deciding, I'm having a midlife crisis, I want to become a fitness instructor, that's what happened to me. That's what I did about 10 years ago. You know, that's a different thing. And you kind of just go with her goals and what she wants to achieve. But it starts with ruling out chronic disease, and then your standard assessments that you do for all of your clients, and then listen to what her goals are. And I think that should get you well on your way.
Awesome, and that should all sound familiar. Working with people is interesting, and you know, there's really usually is just get to know them and get to know them, and always refer out when needed, and get the details and the information, so you just have a point of attack and know what to do and know how to help them best. This has been fantastic. You know, I really think that even just the number of questions that we received from the gallery, and everybody was really tuned into what you had to say today, and I appreciate it greatly, because it's an important topic, and we're working on just, you know, half of the population is going to experience some of what you had said here. So it's you know, not only important for the loved ones that we have and everything, but you know, we can really see professionally how we can make a gigantic impact on everything just using this information. So Dr. DiGirolamo, we thank you so much.
Brian, can I make one more point before we close out?
Please,
and I think this is an
please.
important one. And this is about talking to your clients. In this age of technology, where we've got Dutch tests and we've got apps and we've got all this technology, and I see this in the medical students coming up. They got all this data and they're wondering what's going on with the patient. Did you ask the patient? That's first and foremost, and we are losing that in this technological era. So resist that urge to just turn to the technology and sit with your client for an hour, and you will learn more about her by talking to her, by watching her body language, by connecting with her, than you will from any test you're going to do on her. It starts with a conversation.
I love it. I love it. We've seen it in the field now, and hate to blame the young people, because the older generation sometimes does it too. They get lost in the textbook and they don't realize that the person has a heartbeat there, and you got to get to know it. So fantastic, and it's a perfect way to finish up for today. And once again, enjoy. We'll let you get back to your workouts, right? And thank you so much for everything. And to that, we say to the audience, thank you for tuning in as well. And we hope to see you again very soon for another MedFit Education Foundation webinar. Goodbye.